Good afternoon, everybody. My study was on the effectiveness of carbetocin versus oxytocin for active management of third stage, an open-label study. Postpartum hemorrhage remains to be the largest direct cause of maternal death. Although great efforts have been made to labor, it accounts by active management of third stage of labor. It accounts for nearly 1/4 death worldwide and contributes to long-term disability and severe maternal morbidity, such as blood transfusion, emergency surgeries, and admission to ICUs. So, uterotonics and tranexamic acid are pivotal for the management of postpartum hemorrhage. Decades of prophylaxis have demonstrated that PPH can be prevented by the third stage of labor, of uterotonics during the third stage of labor. Typically, in settings where multiple uterotonic options are available, oxytocin is the recommended agent for prevention of PPH for all births. However, oxytocin is sensitive to heat and must be transported 2 to 8 degrees centigrade at all the times, and this represents a problem in low resource setting where the cold chain is difficult to maintain. So 2018 updated WHO recommendation on the use of uterotonics for PPH prevention recommends carbetocin in scenarios where oxytocin is not available or its quality cannot be guaranteed. Cost is comparable to other effective uterotonics. So heat-stable carbetocin does not require refrigeration, and therefore it eliminates the barriers associated with refrigerated storage and transport for non-heat-stable uterotonics, making this a viable and important option for prevention of PPH. So aim of the study was to find out the effectiveness of carbetocin versus oxytocin in active management of third stage of labor, to compare the blood loss following vaginal delivery, incidence of PPH in women receiving carbetocin and oxytocin, to compare the need for additional uterotonics and blood transfusion in carbetocin and oxytocin group. The methodology to open label study conducted from April 2022 to February 2023 in the Department of Obstetrics and Gynecology, SUT Hospital, Pattam. 194 women, after checking the inclusion and exclusion criteria, were alternatively enrolled to each group. A written informed consent was taken from eligible women at the time of admission. Group 1 received injection carbetocin 100 micrograms, slow IV, injection oxytocin according to the KFOG protocol. Additional uterotonics were administered as and when required. Once the umbilical cord was clamped and cut, a plastic drape for blood collection was placed under the woman's buttock. The blood was collected for bleeding continued beyond 1 hour. The drape with the blood was then weighed by digital scale, with the weight recorded in grams and then converted to volume and subtracting the weight of the drape. So any need of additional uterotonic agent was noted. And the data were expressed as frequency and mean respectively. Independent t-test was used to compare the quantitative parameters between categories. Chi-square test and Fisher's exact test were used to find association between categorical variables. Mann-Whitney U-test was used to compare ordinal parameters. For all statistical interpretations, p-value less than 0.05 was considered the threshold for statistical significance, and analysis was performed by Statistical Software Package SPSS version 20.0. And coming on to the result, gestational age, like age, BMI, gestational age, everything was comparable in both the groups. And mean blood loss was more in the oxytocin group, which comes to 187 ml, compared to carbetocin group, which was 183.7 ml, but the difference was not statistically significant. The p-value was 0.073. So coming on to the incidence of PPH, one case of PPH noted in the carbetocin group, but that was of traumatic type. And need for additional uterotonic agents was more in the oxytocin group, that is 5.2% compared to carbetocin group, which comes to 3.1%. But here also the difference was not statistically significant. And no need of blood transfusion noted in both the groups. The conclusion of my study is carbetocin is as effective as oxytocin in preventing postpartum hemorrhage in women undergoing vaginal delivery. Additional benefits of carbetocin are the thermostability, long half-life, and administration as a single dose. So the choice of carbetocin for routine prophylaxis will depend on the cost effectiveness.
Reshma. Thank you, Dr. Reshma. And coincidentally, the second and third prizes, they have presented the same paper. So we have got Dr. Anisha KS, DNB resident from Rajagiri Hospital, Lalwe, talking on a randomized control trial comparing carbetocin and oxytocin in the third stage of labor.
Good afternoon, everyone. I'm going to, my topic of presentation is a randomized control trial comparing carbetocin and oxytocin in the active management of third stage of labor. The primary objectives of this study were to compare the mean blood loss, the requirement of additional uterotonics, and the postpartum hemorrhage, the requirement of blood transfusion, and the drop in hemoglobin profile, as well as the changes in pulse rate and blood pressure between the two groups. The oxytocin arm, we gave 5 units intravenously, 10 units intramuscularly, with an additional 20 units in 500 ml normal saline over 2 hours. This is as per the K4 regimen. In the carbetocin arm, we gave 100 microgram of the drug, slow intravenously over 1 minute. All the women undergoing vaginal delivery were included in the trial, except those with hepatic or renal disease, serious cardiovascular diseases, epilepsy 8, and we used block randomization for the study. Of the 588 cases, 583 were available for complete assessment. Of the 583 cases which were available, 291 was in the carbetocin arm and 292 in the oxytocin arm. This shows the various modes of delivery in both the arms. As we can see from the chart, the different modes of delivery were equal parity of this among the two groups. When we look at the parity of the study population, this was also almost equally divided among the oxytocin and carbetocin. Most similar. In BMI in both the groups were almost similar. The percentage of induced labor in both the arms, again equal numbers almost. The prevalence of GDM and PIH in both the study groups were almost the same. We had 4 cases of twins in the carbetocin and 2 in the oxytocin arm. VBAC in both the arms. Coming to the assessment part, the mean blood loss was found to be 381 ml in the oxytocin arm, which was about 40 ml higher than that in the carbetocin arm, and the p-value was significant. When you look at the use of additional utero, 53.7% in the oxytocin arm, which was more than 10% higher than that in the carbetocin arm, and the p-value is again significant. When you look at the occurrence of PPH, we had total of 71 cases, 16.3% in the oxytocin arm, which was higher than 11% in the carbetocin arm. The p-value was not significant. We divided the PPH into different types, and when you look at the upper segment atonic PPH, we find 32 cases, that is 45% of the PPH were upper segment atonic PPH. And when you look at the upper segment atonic PPH alone, we find 22 cases, 0.7% of the cases were in the oxytocin arm. This was more than that, double that in the carbetocin arm, and the p-value is significant. When you look at the severe upper segment atonic PPH, where the blood loss is more than 1000 ml, again, of the total 11 such cases, 9 cases, that is 81 cases, were in the oxytocin arm. The p-value was significant. When you look at the requirement of blood products in parenteral iron therapy, higher in the oxytocin arm, but the p-value not significant. Look at the mean drop in hemoglobin, not much of a difference, p-value not significant. The occurrence of malnutrition was the placenta. When you see, the incidence was 3.43% in the carbetocin arm, which was higher than that in the oxytocin arm, but the p-value was not significant. The change in blood pressure and pulse rate was a not significant difference. Coming to the results, the occurrence of postpartum hemorrhage was the mean oxytocin arm, but not statistically significant. The mean blood loss, the requirement of additional uterotonic agents, the occurrence of upper segment PPH and severe upper segment PPH was higher in the oxytocin arm and was statistically significant. The occurrence of manual removal of placenta, though higher in the carbetocin arm, was not statistically significant. No significant difference in the requirement of blood transfusion or parenteral iron therapy or hemoglobin drop. So coming to the conclusion, carbetocin is better than oxytocin in reducing mean blood loss, requirement of additional uterotonics, incidence of severe as well as otherwise upper segment atonic PPH. Does not have any storage restrictions, is easier to administer due to a single intravenous or intramuscular dose. But the cost issue needs to be addressed. Thank you.
I now invite Dr. Sajna Abdul Ghafoor from Aster Medicity to present her poster. You've got 5 minutes.
Good afternoon, everyone. My e-poster topic